yes, I do have my colleagues with me today from Bevan who helped us run this project. And this is actually a presentation, an interim presentation, I guess, because we haven't actually finished our project yet for a number of reasons, COVID being the biggest factor. So I think just to give you sort of backgrounds very quickly, so the Health Board purchased brand new smart pumps back in 2016, and we deployed them with infusion limits already pre-programmed onto these pumps, i.e. a drug library. Because of the massive logistical planning that's required to update these pumps with the configuration and the library, we haven't been able to do the updates on the library as we would have liked. And obviously drug information changes all the time, and it's really important, if you want to maintain the governance of that library and the safety parameters, it's important that those reviews are done. So what we're actually missing here in Hywel is connectivity of these pumps to our Health Board network. So if we had the infrastructure and the connectivity, we would be able to do these updates with the configuration and the drug library in a really good, timely manner, and actually maintain the safety of this drug library going forward. So what Bevan has actually allowed us to do is to actually scope out what this technology could provide us, i.e. the connectivity, and what we can learn from the reporting that happens as a result of this technology. So this presentation is to show you what we've learned so far and what we're going to do next, and hopefully we'll have a conclusion in the March showcase next year. So the first thing that we were interested in is actually, with all this work that we've put into the drug library, are the nurses actually using it? Okay. Part of our intravenous drug administration policy is that all drugs that are infused via these pumps should be done within the drug library. So the first thing we did is we ran the reports to see how many of these infusions that are put through these pumps actually the drug library is used. And when we actually ran the data in March, when we started, we were really surprised by the compliance. I thought, this is amazing. I didn't really think it would be that high. Having said that, I don't actually know what the baseline is because we've never run the reports before. So I'm going to say that this is a good result. But obviously, COVID hit in March and April in our Health Board. And not that we were swamped with COVID patients per se, we were quite lucky in our Health Board. The fear of COVID, the sort of reorganisation of services, the stopping of surgery, the actual number of infusions that were administered by pumps dropped significantly. And as you can see, that shows in the graph. We also noticed that the compliance rate dropped as well. And we think it's because of nursing staff being deployed to different areas, being unfamiliar with the technology, nurses being brought back from retirement or back in from jobs that they'd left, and they were just unfamiliar with the drug library and its use. So we kind of think that might be the reason why the compliance has sort of dropped. Although back in July, we noticed an increase in activity in our hospitals, and so the compliance has started to rise again. Just to let you know that the actual data that we're pulling off is only based on 20 pumps that have been connected to our network, and we have a fleet of about 1,400 pumps in total. So it's a small data analysis if you think about it, and we try to sort of locate those pumps in one area of a ward so that we could actually keep an eye on what the practice was at the time. But obviously when COVID happened, these pumps started to travel out around the hospital, so we didn't actually know where they were. So it was harder to track and actually analyse the data a bit more effectively. So this is where Bevan were really sort of helpful for us. They helped us analyse the data and actually drew up this presentation for us. And the first thing that I noticed with the hard limit breaches that we've had, so when I say hard limits, the drug library is programmed with infusion limits. So it alarms if a nurse tries to administer that drug too fast or too high a dose, because you can actually program the library to do it as a rate, as in mils per hour, or you could do it as in dose, as in mics per kg per minute. So one of the first antibiotics that we noticed was flucloxacillin. I thought, well, that's a bit unusual. I was expecting more kind of high risk drugs to actually flag up as being breached. But actually, when we analysed the library and actually the error, we discovered that, well, I certainly did, is that the library is old, and we haven't actually made it robust enough to reflect the practice on the ward. So I think the limits for that particular drug were too wide. And we actually also learned that we could do something different with the software. We could actually do it dose over time instead. So I think from this point of view, it wasn't real errors that we were seeing here. It was actually the library wasn't reflecting the current practice at the time. And I also noticed as well that when we were looking at the literature for flucloxacillin in particular, there was a bit of a difference between administration rates in one literature source and another. So I think some of the errors that were coming up was because the nurse was trying to administer it faster as per one literature source, but we programmed it differently to another literature source. So that shows how important it is that these libraries are reviewed on a very regular basis to reflect the literature, because the drug library is only as good as the literature that you use to put those limits in. So we were running along quite nicely, drawing off data every month, and then all of a sudden we had an error with one of our pumps where a patient was infused too much insulin. The pump actually administered a dose of insulin far greater than what was prescribed. Now, this was because the limits that were actually programmed into that drug library weren't set high enough. In fact, there was no maximum limit set. Now, as we've been moving along through each year, we've been updating the libraries on a regular basis, but they haven't been installed. So the library was deployed in 2016, and I did an update in end of 2016 for 2017, and that's where I actually put in the limit for insulin to actually improve the safety. But the library was never installed, and I will explain why in the next couple of slides. So anyway, this was an almost catastrophic error for a patient, but fortunately the patient was not harmed. It was spotted straight away and remedial action was taken. So what happened then is there was a sort of mandate from high in corporate that we needed to get these pumps updated with the updated library ASAP. And that's what we've been doing sort of beginning of October up to this point, and we still haven't managed to actually update all of the pumps because we haven't got that Wi-Fi connectivity. We have to update the library and the configuration manually, which means pulling all the pumps back into the clinical engineering department and installing the software pump by pump. And you can imagine over 4 large geographical areas and a fleet of 1,400 pumps, that is quite a logistical task. And it has been for us for the last nearly couple of months to do that. So that is another reason why we want this Wi-Fi connection, and actually has proven how useful and improving patient safety at the end of it, to make sure that this library is updated properly and timely. So we were all along, we've been monitoring drugs and hard limit breaches. What we also found as well, what the library highlighted was specifically what advantages the library has to nursing staff, is that when you have, for example, patients step down from critical care areas where perhaps they use specific drugs for that area, and then they're transferred to a general ward area, perhaps still on those drugs, I think the library there is a fail-safe for those unusual drugs that nurse may not be familiar with. So we did notice some hard limit breaches with caspofungin in particular, which you would normally see administered in specialist areas and not on a general ward area. So obviously we saw a couple of breaches with caspofungin, so we think, well, that's a really good demonstration of how that library prevents or supports the nurse into checking those unusual drugs. We also found limit breaches with vancomycin, gentamicin, so those drugs which have got a narrow therapeutic range and really do need to be administered correctly. So that was a good sign as well. So that's just a bit more detail. We've also noticed as well frusemide. This is a real bugbear of mine because it keeps happening. We've noticed this is another example where the drug library doesn't reflect some specialist practice in certain clinical areas. Now, normally with frusemide, you can administer it on a general ward, perhaps in a bag, or maybe you could give it bolus without a pump. But normally the limit is 4 milligrams per minute. Now, for certain patients, particularly heart failure patients, there is a specialist way of administering frusemide, and they make it up in a syringe and they administer it, say, 2 mils an hour. And what we found is because there's this variation in prescribing, it's not standardized. I think nurses are getting confused by what's written on the prescription charts, and there we've had some limit breaches. So what we've tried to do now is actually reflect that in the library and make a frusemide entry more specific for those particular areas. So it's kind of adjusting the library as and when you need to. So obviously, if you're making those changes, you need to be able to put that out on the library and on the pumps as soon as you can, and not wait 8 weeks for it to be installed manually. So the Wi-Fi connection will help with that. This is an example of where you can use the software in certain ways as well. You can either do it as rate, as I've mentioned, or you can do it dose over time. And this is mostly for things like antibiotics, where you have standardized doses over 30 minutes or 20 minutes, and you can program the library as such, which is why I reflected on the flucloxacillin. I don't think the library was reflecting that practice enough. It wasn't working for the nurses. So making that change is really important. Okay, so there's other things you can do with the software as well. You can put in messages on the pump to flag up when the nurse uses particular drugs. Now, we noticed in our medicines event review group, or our patient safety group, we had a lot of data regarding nurses administering penicillin-based antibiotics without checking the allergy status on the drug chart. Now, what we thought would be like a risk reduction strategy is we could remind nurses before they administered the drug to check the allergy status. So the message now comes up on the pump to remind the nurses to do that. And we've done similar messages with other antibiotics like vancomycin, gentamicin, where we've had other datexes where things have not been prescribed properly, or the vancomycin hasn't been written on the infusion chart properly. So it reminds nurses to go and check guidelines before they administer it. And we're hoping that in the next few months we can monitor our datex reports to see if that actually has had a change. This slide here is just to demonstrate why, or the difficulty that we have in uploading our drug libraries and our configuration manually. The amount of time it takes to update 1,400 pumps across 4 geographical areas, it's taken us nearly 8 weeks so far, and we still haven't done every single pump. If we had the Wi-Fi connection, we would be able to update our devices, probably 92% of them, within 4 days. And that is quite amazing to me. I really want to see this happening. And obviously then you have to do subsequent pumps updated later on, because it all depends when they're actually connected to the network, when they're not in use. So when they're not in use, they then connect to the network and they can receive the update. Just like you get an update on your apps on your phone, it's the same kind of process. So Wi-Fi connection would be, well, it would revolutionize our drug library, because we'd be able to update it instantly. It would be amazing. And certainly in these unprecedented times where things are changing, critical care regimes are changing, new drugs are coming out, it's what we really want. So I reflected on the prudent principles of the Bevan Commission, and I think it is essential, if anyone has this technology, and certainly for us going forward, that it's done in a multidisciplinary way. It's not just pharmacists creating a library and installing it. It needs clinical engineering to be involved, the MSOs, the medical device safety officers, nursing teams, clinicians, to actually make that library the best that it can be to reflect actual practice. And at the same time, you are reviewing your practice. Is this the safest way to do it? Can we change it? Can we standardize anything to reduce variation? And actually getting all those people involved is the only way that this technology will be smart, and how we become smarter in reading those reports, analysing it, and actually prioritising work streams as a result to improve patient safety. So the collaboration and the partnership is really, really important. So in summary, we've had a hell of a year. The update wasn't planned, but I'm glad that it happened. I know it was an error for a patient. I'm so glad there was no harm, but it actually spearheaded so many things to happen as a result, which I'm glad about. And now I think we're in a position where we have a more comprehensive library out in circulation. We can now run those reports to see how we can make further improvements, and actually we can target specific areas now, because I think what the reports that we'll run will reflect more of what's happening on the ground and those errors, rather than the fact that the library isn't good enough because it hasn't been updated over the last 4 years. Do you know what I mean? So we've actually acquired through because of COVID, and the sort of mutual aid that we have across Wales amongst our health boards, we've acquired 200 extra Wi-Fi connected pumps, which will be amazing. And we plan to deploy these pumps to critical care, so that we can actually monitor the reporting coming from critical care. And with all the COVID trials that are happening and the new drugs that are being used in critical care, we need to make those updates to the library really quickly. And that's what I want to see next, is how that actually happens with individual drugs, and actually monitor the effects. So hopefully when we come back in March, we'll have some more interesting data to share. And then, sorry, I forgot to say, going forward, this work is going to be shared across Wales. I have colleagues in Cwmtaf who are in a similar position to us, where they have the Wi-Fi technology, and they've just gone live with their library, and we want to share our learning from the reports that we run off from a safety point of view, to look at those near misses, to look at those themes, so we can all learn together. And that's it.